Good afternoon, everyone. My name is Dr. Jodie Guest. I'm an infectious disease epidemiologist and professor and vice chair of epidemiology at Rollins School of Public Health here at Emory University. I lead Emory's COVID-19 outbreak response team, and I'm the host for Emory's COVID-19 videos where we cover important topics about the pandemic, which is still going on. Today, I am pleased to be joined by my friend and colleague, Dr. Carlos Del Rio, so that we can update you on the latest COVID-19 information. Dr. Del Rio is well known to all of you. He is a distinguished professor of medicine, epidemiology, and global health at Emory, and is the executive dean of Emory University School of Medicine at Grady Health System. Welcome, Dr. Del Rio, and thank you for joining me again today.
Happy to be with you.
Thank you. Very quickly, let's go through some numbers. It's been a little bit of time since we've done a video like this. So here's what COVID-19 looks like across the United States today. Following a long period in which new reports of cases were relatively consistent, the number of cases in the United States is again on the rise. The daily case average grew to more than 129,000 on Tuesday, and cases are rising in more than 40 of our states. Test positivity rates are also increasing sharply across the United States. Some models are estimating the numbers that we're currently showing for COVID-19 might be as much as 7 times less than what is actually circulating in the United States, based on the fact that so many people are now using antigen tests or at-home tests. The increases come as the BA.5 variant, believed to be the most transmissible variant yet, is emerging as the country's dominant virus strain. Hospitalizations are also rising in the United States, with more than 37,000 people in the hospital with the COVID-19 on any average day, which is an increase in 17% since the beginning of this month of July 1. Deaths are also up 25% from a month ago as another marker of increasing rates of cases. So let's start with case numbers. Dr. Del Rio, the CDC has 2 maps that they've used to provide and describe levels of COVID-19 in the United States. First, there's the COVID-19 community levels map that can be used to determine the impact of COVID-19 in communities. And they suggest that this is your take action map. I'm going to show both of these in a moment. This map uses 3 metrics. The first is how many known cases per 100,000 a community has in 1 week, adding them all up. The second is 2 hospital metrics. One is the total of new COVID-19 hospital admissions in that week and the percent of inpatient beds in that week being used with COVID-19. Looking at this map, and let me get to it. 1 second. So looking at this map, and this one I'm talking about here is on the right, what we see is about 35–36% of the United States is in this high area of transmission. What are your thoughts about how this map represents what's going on with COVID-19 in the United States?
Well, I think these 2 maps are looking at 2 very different metrics, and I think it's confusing for people to see this, and it's confusing to see. And I think you can look at it in different ways. I think one of them is talking about community transmission, and the other one is talking about impact. And you in both of them, you see a very different thing. And in community transmission, you're really looking at how much cases are happening at the local level. And as you say, cases now are not a great indicator because a lot of testing is being done that is never reported. On the other hand, the impact is looking at things we can actually measure, which is test positivity rate, is looking at hospitalizations, is looking at other impacts in the community. Both of them are telling me right now that there's a lot of transmission in our country. There's a lot of transmission. And we, for example, here in Georgia, a fair amount of Georgia and a lot of, for example, Florida is in a level that CDC would recommend use a mask in indoor settings. And I would add to that, I said, use a high quality mask in indoor settings, because the reality is that this is a very transmissible virus, and you are likely to get infected no matter what. Now, that takes me to the other component is you also want to be vaccinated and you want to be boosted. And recently CDC changed the definition of what up-to-date in your immunizations it means. And if you're over the age of 50, you really need to get a second booster. And the percent of the population that has not received a second booster is pretty high. So we're seeing more people in the hospital. And I can tell you that most people with COVID we're seeing in the hospital are either unvaccinated or people that have just been vaccinated but non-boosted. you really need to get your boosters if you are to be protected from severe disease, hospitalizations, and death.
Yeah, and we're going to talk a little bit more about all of those excellent points in a second, because they're so important and they're a little different now than they were at different points in times as we've talked about this pandemic. So as you alluded to, Omicron subvariant BA.5 began to spread in the United States the first week of June. It's now 78% of the cases in the United States. It's still classified as an Omicron variant, but it has some new mutations that are different from the Omicron variants that we had previously, the subvariants BA.1, .2. A lot of people say that this is the mother of all subvariants from what we've seen so far. Is it more transmissible than BA.1 and .2?
This is probably more transmissible, but not only is it more transmissible, but it's more immune evasive. And I think the key here is that word immune evasive. In other words, just because you're vaccinated or just because you're boosted doesn't mean you're protected, or just because you had a prior infection. We're hearing a lot of people who are getting reinfected, who had Omicron in January or February or March, and now are getting infected again. Getting infected is not protecting you from infection with this variant. So to me, the combination of more transmissibility and higher immune evasiveness is really what makes this a very complicated variant.
And immune evasiveness does not mean that the vaccines are not working. It just means that they're not preventing you from getting it as well as it did against other subvariants.
We go back in history, and history is only 2 years old, but
right.
When the vaccines were designed and when the clinical trials were designed, they were designed to test vaccines, to make the vaccines work against severe disease, hospitalization, and death. They were never designed as vaccines. Then nobody expected these vaccines to be very good in preventing infection. By sheer luck, when the vaccine clinical trials came out, it looked like they also prevented infection, and we were like thrilled. We were all excited, saying, "Wow, this is like getting a gold nugget out of your excavation." We were not expecting this, and this is totally unexpected. We were looking for silver and found gold, right? But then shortly thereafter, we realized that this was a very short-lived success. And in fact, as soon as the virus mutated to Delta, we realized that they weren't that good to prevent you from infection in Delta. And as we look at how this virus is becoming more and more different than the original virus, and BA.4/5, I mean, if you look at maps, as the virus evolves, this virus is way out here. This is really out in the periphery. So it really antigenically is very different from the original virus. Then the level of protection against infection is almost gone. It's almost disappeared. But the level of protection, because it's a different level of protection against severe disease, hospitalization, and death, is still there. It's still very strong, but it has also lost efficacy. We used to think that 2 vaccines were sufficient, where they clearly are not sufficient. You need not only to be boosted, but you need to be boosted again. You need to be boosted twice in order to really decrease your risk. And as I said, my biggest concern is that if you look at the data, a lot of our population of the age of 50 is not boosted once. It's nowhere close to being boosted twice. So we're going to see people who are, who thought they were okay coming into the hospital with severe COVID because they're not okay.
Yeah. Let's talk for a moment about symptoms associated with BA.5, BA.4 and .5. Clinicians are now saying that the symptoms seem to be very similar to those of previous variants, with the more recent variants, subvariants under Omicron: congestion, headaches, cough, and fever. Is that what you're seeing as well?
Yes, but what you also see is a lot of sore throat, and people frequently confuse the sore throat with something else. I've had so many people say, I thought I had strep throat because I had this really bad sore throat. And that's a very common sign now with BA.4/5. So keep that in mind. Sore throat is a very common symptom. Also, you get a cough, frequently a dry cough. It may be productive sometimes, but a dry cough, nasal congestion, sort of like, I would describe it like a bad flu, muscle aches. And another symptom that I'm hearing a lot about is fatigue. people say, this really wiped me out. This really has me down in my knees, and I feel like I cannot function normally. I'm really wiped out, and that's also something we're seeing a lot.
I've also read some case reports that children are tending to have more GI distress with this particular variant than we've seen in others, and that it's seen more in children than in adults. So that's something a little different to be watching for if you have a child at home who has any of these symptoms as well.
I think diarrhea is a pretty common symptom in children.
Yeah. There's a lot of talk about reinfection, and you brought it up a moment ago. People who had earlier subvariants of Omicron seem to be equally as susceptible of getting BA.4 or 0.5. There's some confusion that means I can get BA.5 more than once. What do you think the likelihood is that it will stick around long enough that people will actually be reinfected with this same subvariant?
It's hard to know. I mean, the way the virus has evolved recently and the way variants have come and gone, and there's competition. I mean, it's a Darwinian world out there in which the variants are emerging and then rapidly displacing the other one. I don't know what's going to happen next. I mean, I think that if there's one thing that we have learned in this pandemic is as scientists, we have to be humble. Predicting the future is not in our best interest, because I can't predict the future. I can tell you what's happening now. I can tell you how to protect yourself as best as you can, but I cannot predict the future.
That's fair. That's fair. Talk to me about hospitalizations. They are lower than other surges than we've seen, certainly lower than what we saw during Delta, and that has been true across all of Omicron, but they are up 8% in the United States in the past 2 weeks. Why are we seeing fewer hospitalizations with this variant, or are we just not seeing them yet?
No, I think it's, we build immunity, right? Between vaccinations and prior infection, while their immunity is not perfect, immunity is not like a light switch on or off. There's certain levels of protection, and as we're building more immunity, we are in a way becoming more and more resistant and developing better protection against severe disease and hospitalization. And this is something that I was telling people. Biden infected today is not the same as Trump when he was infected. Biden is, and they're all over the age of 70, but Biden is vaccinated and boosted. Trump was not. Biden has access to Paxlovid. Trump did not. So I think it's a very different scenario. So we are better off today than we were before, because we have vaccines, we have boosters, but we also have access to testing, access to therapies. There's Paxlovid, there's Molnupiravir, there's Bebtelovimab. Access to therapy is making a huge difference. And you saw the president's already started on therapy. When Tony Fauci got infected, he got started on therapy. Therapy makes a big difference.
Yeah, absolutely. So let's talk about boosters. Just to remind everyone watching, at least one booster is recommended for anyone over the age of 5 in the United States. And anyone over the age of 50 is eligible to receive a second booster, as is anyone over the age of 12 who has any sort of moderate or severe immunocompromising condition. So that is a large portion of the United States. So first of all, back to what you were saying earlier, do you think that this is the best measure of how well vaccinated the United States is now, is to look at the number of people who've been received at least one booster, which currently is 48% of the United States for those over the age of 5 versus those who have been fully vaccinated with our original definition of what that meant?
The problem is that the terms are really confusing, right? Fully vaccinated, to me, fully vaccinated nowadays, the CDC uses the term up-to-date in immunizations, and I'd like to use that term. I think the fully vaccinated is a confusing term. If you have received 2 doses, in my mind, you're not fully vaccinated, because you're inadequately vaccinated. And I think we need to call it what it is. And I really don't think it's appropriate that CDC calls that fully vaccinated, because those people essentially have very little to no protection against severe disease and severe outcomes. So you need to get, you need to be boosted, and especially if you're over the age of 50, you need to receive not only your first, but your second booster to be to be up to date in your immunizations, what I call fully vaccinated. And then percent of the population over the age of 50 who has received 2 boosters is exceedingly low. And that to me is the biggest concern that I have right now.
Yeah, not only is it low, it's 28.5% of the US population over the age of 50 has received their second booster.
Yeah.
28.5%. That is very low.
That is incredibly low. And I think two things are happening. Number one, people think this is over, right? I mean, most Americans, COVID is something of the past. They're not concerned about it anymore. But number two, I think we have been really bad of messaging, right? I still think the term fully vaccinated, if you're, Joe Smith in the street and I say, have you been vaccinated? And I look at your immunization card and you say, yeah, I've been fully vaccinated. So why do I need to get boosted? I think I don't like the term fully vaccinated. I think it's confusing. And I think it creates, people not wanting to get boosted because they're fully vaccinated.
Up to date is a much better term. And it also shows that it can be a moving target.
Yeah.
Which
it is a moving target.
Yeah. It's unfortunately still a moving target. Let's move to something new that's happened in the past month and a half or month or so. On June 18th, the Centers for Disease Control and Prevention endorsed the Advisory Committee on Immunization and Practices recommendation for all children 6 months through 5 years of age to receive the COVID-19 vaccine. So this is something that parents have really been waiting for, and it came to fruition in the middle of June. The Pfizer vaccine was approved for children 6 months through 4 years, and the Moderna vaccine was approved for ages 6 months through 5 years. A little bit of data about COVID-19 in children. While it is rare for them to become seriously ill, they can. In fact, more than 1,000 have died, and more than 40,000 children in the United States have been hospitalized for COVID-19. And additionally, 8,500 of them have developed multisystem inflammatory syndrome, which can cause inflammation of internal organs and can be fatal. So let's back up to those differences in age ranges for this vaccine. So again, Moderna is for 6 months through 5 years of age. I'm sorry, 6 months through 4 years of age for Pfizer, and Moderna is 6 months through 5 years of age. Why do we have the difference in age ranges there?
Well, it's how the clinical trials were done, and it's how the data was presented to the FDA. And again, FDA looks at the data and makes decisions based on the data, and the studies were done differently, and that's why you have that difference. Also, I mean, to me, the biggest difference is that Pfizer is already approved as a 3-dose series for children. Well,
Right.
Moderna is a 2-dose series, but I can tell you, you're probably going to need a 3rd dose later on of the Moderna vaccine. So it's even more confusing for parents, quite frankly.
Yeah, absolutely. Yeah, so thank you for pointing that out. Pfizer is a 3-dose series. So to be up to date for your children in that 6 months to 5 year range, you need 3 doses of Pfizer, 2 doses of Moderna to be up to date currently.
And I will tell you that the uptake in children under the age of 5 has been exceedingly low. I mean,
Very low.
About 3% of children 6 months to 4 years have actually received 1 dose, and even lower 2 doses. So it is very, very low. And again, part of it is parents are confused, and parents are not knowing what to do, and pediatricians are confused.
Do you think the fact that there's so much COVID-19 right now and people still believe that the vaccines were meant to prevent transmission is undermining people's trust in the vaccines?
Oh, I think so. I think so. I mean, we have a lot of transmission, and seems like the vaccines are not working when they really are. And as I said, we conflated the message, we confused the messaging, and we keep on talking about, well, these vaccines don't protect you against infection. Well, they were never designed to protect you against infection. Right. And they give you some protection against infection. They're not zero, but it's not 100%. And right. And you add to that, how much transmission there is, and yeah, the trust in the vaccines is really out the window. Now we must recognize that these are not, great vaccines. There is a lot of issues in the vaccine, including, why so rapidly waning immunity, and that's something that needs to be understood. And I think I would call these vaccines 1st-generation vaccines. We will have better vaccines later on, but these are not the perfect vaccines we all wanted, right?
But if we're going to have better vaccines or perhaps even enhanced boosters coming up in the fall, no one needs to be waiting for those, right? We should
Oh,
take advantage
absolutely.
of the vaccines we have
Correct.
now.
If you're eligible, you should take it.
Okay. Let's move on to testing. Big news today, President Biden tested positive for COVID-19. There are some interesting things about the information that's come out about him testing. First, as you said, he is up to date with his vaccinations. So he has received his 2 primary doses and two boosters, and he started therapeutics immediately. Additionally, they're going to test him to come out of isolation, which is a little different than what we have had in some of our guidelines. Let's talk about who should test right now and when you should test. Generally speaking, people should test if they have an onset of symptoms or if they've had an exposure. It's also a great idea to test before you go to an indoor gathering, particularly if you're going to be with someone who might have really hard time if they were to get COVID-19. Back to the symptoms.
Well, I think about it depending on the test. And when we're talking about testing, the most available tests right now are antigen tests.
Right.
And what I tell people is if you have symptoms, test yourself with an antigen test. Having a negative antigen test when you have symptoms does not mean you're not infected. You need to repeat the test 24 hours later, because frequently will take a little bit of time for the test to become positive. You need to get certain level of antigen in your secretions in order for it to be positive. So if you have symptoms, consider yourself infected and isolate, and don't trust a negative test. 2 negative tests, it's a better indicator that nothing is going on. A PCR certainly is different, and if you have access to a PCR, that's a good way to know whether you're infected or not. If you're testing, for example, if you're going to go visit an elderly relative, again, my recommendation, you don't have any symptoms, because I would start with that. If you have symptoms, don't go.
Right.
No, if you're going to go, I mean, people that say, oh, I went to this dinner party and I just thought I had allergies. No, if you have symptoms, don't go. Because I've heard that story so many times. I just thought it was allergies and therefore I didn't worry about it and I went to the party. No, if you have symptoms, don't go. But if you don't have symptoms and you say, I'm going to go to this gathering, test yourself 24 hours before you get together and test yourself literally as you're walking in the door. 2 tests. I always tell people, the package, most of the test packages have 2 tests. And one of the reasons is because you need to use 2 tests. One test is not good enough. Use them 24 hours apart. And I think, 2 tests gives you a lot more probability of a true negative than just doing 1 test.
I think that that's incredibly important. If you have been out and about and maybe traveling, maybe you've been to a concert recently.
Or you just came back from the Middle East like the president, right?
Right.
He was in Europe. He was in Europe and the Middle East. He's another example of somebody who was on a long, a foreign trip and came back and is infected.
Yep. And tested. So the good news is he tested when he got back. Is that the thing that we should be doing? So if I came back from a trip, let's say I've been traveling with President Biden, I come back, should I be testing even if I don't have symptoms when I arrive home?
The answer is yes. And what I recommend is you don't necessarily need to test just when you arrive. I recommend you get tested, 5 days after you return, sooner if you have symptoms. But, I just returned from a trip to New York City. I returned a Sunday night. I'm going to test myself tomorrow. I have a rapid test at home. Again, there's a lot of access to rapid tests right now. You can get them from the government for free. I'm going to test myself tomorrow. I think it's a really important strategy of picking up early infection.
I think that that's so important. And yes, now is the round 3 of being able to get antigen tests for your home from the US government. So everyone should sign up to receive those. What about if you have a known exposure? So what we were talking about is more of this vague, I've been out and about in large groups and there's a lot of COVID-19 out in the world right now. What about if I know I was with someone and they have tested positive for COVID-19? With the new variant, what's my testing strategy timeline for when I should start testing myself if I have no symptoms?
I would say at 3 to 4 days. Most people are going to be positive within the first 5 days, but 3 to 4, maybe 5. So maybe test yourself once at 3 and once at 5 days after a contact. CDC recommends if you're up to date in your immunizations, to test yourself at day 5.
That sounds great. Now, let's say your test comes back positive. So talking again about President Biden today, his test came back positive. And so we are hearing on the news what is happening with him. Let's walk through what people need to do, because this has not been the easiest of guidance to understand and to follow. If you have no symptoms, but you've tested positive, you are asked to isolate for 5 days. And if you consistently still have no symptoms after 5 days, then to mask for an additional 5 days, for a total of 10 days of masking, but 5 days in isolation. If you have symptoms or develop symptoms at any point in time after your positive test, if you are no longer feverish, so if you've had no fever after 5 days, then you can leave isolation and continue to wear your mask for 5 days. But if you still have symptoms, you are to stay in isolation for all 10 days, right?
Correct.
So President Biden, and there's a new caveat to the CDC guidance, which he is following, in order to come out of isolation at day 5, the suggestion is if you have access to at-home rapid antigen tests, to test at the end of that day 5 of isolation. And if it is negative, to then feel more confident coming out of isolation, again, assuming you have no symptoms and particularly do not have a fever. But if it's positive, the guidance is to actually stay in isolation.
Correct.
So I like the 2-day testing at the end as well. So if it's positive on day 5, I would want to test again.
What actually be the problem with President Biden, and the problem we're seeing also, is that he now started in Paxlovid. And
Right.
because of that, his test is going to be negative at day 5 or 6. But then he may have a rebound, and he needs to be watched for rebound, and he needs to be retested, and he needs to be watched for symptoms.
Let's talk for a moment about that Paxlovid rebound. What is that?
So the Paxlovid rebound is that you finish your 5 days, you're doing fine, you're feeling great. And then 3 to 5 days after you finish, you start getting symptoms again, and you again test positive. So basically it's like you didn't totally eradicate the virus, and the virus is coming back with a vengeance. And people tell you sometimes the rebound is much more milder than disease. Some people tell you that the rebound could be worse than the disease. Is not recommended by the FDA that you take another course of Paxlovid. I must say that Tony Fauci took another course. That's not what the FDA recommends. The problem that you have, some people say, well, I'm reluctant to take Paxlovid because if you have a rebound, instead of isolating for 5 or 10 days, now you may be isolated for 2 weeks, right? Because
Right.
your clock starts counting again. So, and that's why I think it's only people over the age of 60 or 65 who should be treated with Paxlovid. If you're younger than 60 or 65, there's no point on taking Paxlovid because it's not going to change your course and may actually prolong your course.
Okay. And to put a little bit more of a fine point on this, if you are testing positive on an antigen test, even if it's in a Paxlovid rebound, you are still contagious, or you are contagious.
If your antigen test is positive, you are contagious. Yes. The PCR is a little different. PCR may detect dead virus, but the antigen test is to me, it's a symbol of infectivity.
Okay, that's exactly how I think of it as well. And I think that's really important for everyone to remember. So that is why it's really important, if you have access to an antigen test at the end of your 5 days of isolation, to use it. And if it's positive, you're still contagious. And
especially because your highest risk of infecting others is within your household, right? And we all want to protect our family members. So don't go out. I mean, I tell people, if you can stay in isolation for 10 days, just stay the 10 days and then test yourself after 10 days. You don't want to come out of isolation still having a positive antigen test, because you will sit at the table and, will hug your kids or you hug your parents, and you can still be infectious. So after you've been positive, if you want to, sort of take your mask off and come out of isolation, is use testing as a strategy.
I agree. And I think it's important to note that with some of our newer variants, there's a lot of data to show that people are not testing positive, or a decent portion of people are not testing negative after day 5. It is lengthened, and it's not uncommon to be testing positive at day 9, 10, 11, even 12.
Right. And that's why, again, if we have access to testing, and in this country, we have access now, use testing, because testing is something that can really guide you in your decision-making process.
Do you feel sometimes, Dr. Del Rio, like you and I and others are howling into the wind? Wear your mask, please test, get a booster.
Well, we're clearly not being effective because there's a lot of transmission out there, and quite frankly, sometimes I'm like, there's nothing else we can do, right? I mean, I think at this point in time, we're seeing the virus pretty much loosely in our communities. There's not the public health response to the pandemic is over. That doesn't mean the pandemic is over.
Right.
But that means we all then need to take matters in our own hands, right? And what that means is you need to make the best decision for you. And your best decision for you is to be vaccinated, to be boosted. If you need a second boost, to be second boost. If you're going to go to a crowded place, to wear a mask, a high quality mask. If you get symptoms, get tested. If you are qualified for treatments, get treatment. And if you do those things, I think that's how we're going to live with COVID for the next several months, if not several years. This is the new reality until we have better vaccines and until we get better control on this virus. And I think I'm not saying people need to stay in their homes, not go out, have lockdowns. No, that's not what we need. That's so 2020s, right? In 2022, we have a different strategy, and the strategy is how do we live with COVID? There was an article in the New York Times the other day saying, endemic COVID this is what endemic COVID is like, and it's brutal. And that's true. This is not normal life, and this is hard. But if we do the things the right way, we may be able to continue, doing some of the things we enjoy doing. We're traveling, we are, going to restaurants, we're getting together with family, but there's ways to do it in a more safer way.
Yeah, I agree. I know you said you didn't want to predict the future, but I'm going to ask you one more forward-thinking question. Do you think we're in for a surge of another variant in the fall? And do you think we will have another round of boosters being recommended coming this fall?
So the way we've seen this virus evolve, yes, we will have different variants. I'll be surprised if all of a sudden the virus doesn't produce a new variant, because, since Omicron, we've seen variants come and in a way that it's almost, faster than I can keep them in my mind. So yes, there'll probably be different variants and new variants. My hope is also that we are, as a country, building better and better immunity. And hopefully, as a result of better and better immunity, we will be less and less impacted in a significant way. So we'll keep our hospitalizations low. We'll keep our deaths, will drop, and they're not low right now. More than 300 Americans are dying each day from COVID. We need to get a lot lower than that. But we also need to recognize that COVID is going to continue disrupting our lives for the time being. And that is a reality we have to accept.
Yeah. And one of the ways to deal with that disruption is to do what you can to keep yourself, your community, the people you love, and the people you're around safe. And doing that includes the things we've been talking about for a long time: staying up to date on your vaccines, using the new term, Dr. Del Rio, and wearing a mask when you're in a larger filled room indoors with people is a good idea right now. It does not mean forever. Absolutely. But it is a really good idea right now with the level of spread that we have out there.
Absolutely.
Dr. Del Rio, as always, thank you so much for coming and speaking with me about this. We appreciate your insight and the fact that we've been able to call on you so much in the past 2.5 years to give us guidance. To all of you watching, thank you so much. And please stay safe out there.
Thank you so much. Take care.